Well, I would say the first thing is that it's a team effort, and it's not a one-time decision, because a cataract surgery is a once-in-a-lifetime opportunity to get the type of vision that the patient wants, and to minimize their dependence on glasses if that is what they wish. And that is not something that not a decision we expect people to make just off the bat. So the best way I can describe it is we always educate our optometry colleagues and ask them to start the conversation with the patients about the types of lenses that are available. And we'll also ask for information from our optometry colleague about what the patient's refractive history has been. For example, what power have their glasses been in the past? What has been their best corrected vision that's documented at the optometrist? And what's happened now? And that can uncover subtle problems, like if the patient has an eye that's lazy and isn't quite as good in the other eye, then we know to underpromise a little bit or not to use certain types of lenses. So the first thing is the conversation starts at the optometrist, and all that information we get from them is very rich in terms of helping us counsel the patient about the lenses. Then what happens is the patient comes to see us for an assessment, and we ask them a whole lot of structured questions. So every patient gets asked the exact same question about their lifestyle, their hobbies, what they wish to do, what they currently wear glasses for, and whether they wish to minimize their glasses dependence, how sensitive they are to light, do they do many activities at nighttime, etc. So once we ask them all those questions and gather all that information about the individual patient, then we go through with them and show them a simulation, an online simulation of what the different lenses are, and I'll go through them with you now. So a typical or standard lens is called a monofocal lens, mono being one and focal meaning one focal distance. So it's clarity and at one distance range, and usually that's either long range, intermediate, or up close. And that's all that lens can achieve. It's still a wonderful lens, still excellent clarity, excellent technology. It's made of the same material as the other more premium lenses, but it can only do one thing. Okay, so basically lots of people come in and say, oh yeah, I don't mind wearing glasses to read. And then I say to them, well, hang on a second, based on the questions I asked you, what do you mean? Like, do you not mind wearing glasses when you're cooking and reading a cookbook, because that's an intermediate activity, and that's also classified as reading? Do you not mind reading the dashboard, putting on your glasses to read the dashboard in the car, because on some dashboards the text is actually quite small, and again that's at an intermediate distance. So it's really about having that detailed discussion with the patient. So that's a monofocal lens. With monofocal lenses, if the patient has any astigmatism, so astigmatism correction called a toric lens can be built into any of these lenses. So a toric lens corrects baseline astigmatism, and correcting baseline astigmatism is absolutely essential for getting a really sharp result, whatever our goal is. So monofocal plus or minus toric as per the patient's needs. Second category of lenses is called extended depth of focus. And I explained this to patients as it's a 2 out of 3 range of vision. So when we talk about 3 ranges of vision, we talk about 6 meters, which we call distance vision, intermediate vision, which is about arm's length or 66 centimeters, and then reading vision, which is 30 to 40 centimeters, wherever the patient likes to hold whatever they're reading. And so an extended depth of focus usually covers 2 ranges of that. So we can aim the extended depth of focus lens for distance, then they get distance and intermediate. Or for many patients who have been short-sighted all their lives, they've told me, oh, look, I'd really like to read the computer without glasses, read my book without glasses, but I don't mind wearing glasses for distance, for driving and pottering around the home. I'm a -2, and I usually potter around the home without my glasses as it is. So in those patients, we can put in an extended depth of focus lens, but bring that zone back so they get intermediate and near. And within this category, there's a really clever thing called a mini blend. A mini blend is where we test the patient's dominant eye, and we put in the extended depth of focus lens in that eye, aimed for distance, because the brain will favor that one for distance. And that'll give them distance intermediate, so 2 out of 3 zones. And then non-dominant eye, will pull it back a half a diopter, which is practically an imperceptible difference to the brain, and that half a diopter will bring it back to intermediate and near. So that mini blend with both eyes open allows the brain to see a seamless range of vision from distance right to intermediate, right through to up close. So that's quite a clever thing that we can utilize those lenses for. And because it's such a small difference, like I said, 100% of patients tolerate that, because most eyes have a half a diopter difference in their prescription as it is anyway. And the final category is called a multifocal lens. So multifocal lens can mean many things, but really it's about the result that the patients get. And the result that the patients get is approximately a full range of vision, distance, intermediate, and near. And the individual lens does all those three distances. And when we put them in both eyes, then that gives you, of course, good fusion and excellent stereopsis. When I speak to patients about these lenses, I always say, look, no lens is the panacea. Panacea is the Greek god of healing and all things good and making everything right. So no lens is the panacea. And if we start from accepting that point, then we can decide on the trade-off that the patient's willing to accept in order to get an either greater range of vision, etc. So with multifocal lenses, the technology is getting better and better all the time. There's many different ways that the manufacturers can achieve this multifocality, or being able to see at all those different distances without glasses. But the vast majority of them have a side effect of impaired or reduced contrast. And that may not be a problem because people do adapt to it. And patients can get some nighttime glare and halos, which are like little starbursts around headlights or traffic lights when they're driving at night. But again, the vast majority of those patients, upwards of 80% adapt to them, 85% adapt to them over 6 to 12 months at the latest. And the way that I look at that is, going back to those structured questions we asked patients at the beginning, people who tell us that they've always been sensitive to light their whole lives, they've been more sensitive than their friend or their family members, they've always got to wear blackout sunglasses and hat when they're outside, well, their retinas are naturally more sensitive to light. And just like some of us are more sensitive to sound, more sensitive to touch, there are some people who are like that. There's biological variability. So for patients who are more sensitive to light, we generally don't recommend these lenses because they may be struggling a little bit more to adapt to them in the future. Whereas with the right selection, putting that lens in the right patient, they can get a really outstanding result.
So if I'm understanding correctly, so multifocal lenses are great, but they potentially have a side effect for some people of like maybe nighttime vision has some
Correct.
complications. Yeah.
Yeah,
Okay.
no, I wouldn't say it's not complications. It's basically the nighttime vision in some people will just not be 100% crisp. There'll just be
Yep.
little lights coming out of very, very bright lights when the surroundings are extremely dark. And that tends to be during driving. If you're walking around in a busy metropolitan area at night, you won't really perceive the problem because there are so many lights. There's a lot of actually ambient light around.
Right.
So really the only time that patients notice it is driving on a darker road and when there are fewer cars coming towards them. And like I said, it generally only affects a small portion of patients and the majority adapt to them, but it's all about selection. And the patient's doctor will be able to guide them through it and see if they're a good candidate.
Well, I like what you said about this being maybe a once in a lifetime opportunity to correct some vision issues that people have had for a long time. Whether
100%.
that be like astigmatism or even like presbyopia and so on. Did you say that you can give patients a simulation of the different types of lenses?
Absolutely. So there's an online simulation which we show them with each lens and what it will show them. It's not like a virtual reality simulation where they can put the headset on and see, but it's patients get a pretty good idea because it's a very good simulation. And there's even a nighttime mode for each lens to show them what these glare and halos may look like with certain lenses. And there's an adaptation mode where you click the button and say, well, this is what happens when people adapt to it, which is the majority of patients. And people are quite reassured by that.
Wow. So isn't modern technology amazing?
I know. So in many ways, the art of cataract surgery is really the conversation that happens at the pre-op and the selection. The rest of it's easy. The rest,
Okay.
slick cataract surgeon can do a lovely, lovely cataract, really good result. But the thing that's going to make the patient happy is having the right conversation and tuning in exactly to what the patient's saying, to what their needs are, and using our experience to help them select the lens that's going to make them the happiest.
Did you say that there's some like brain adaptation phase after the surgery?
Yeah, absolutely. So look, some patients, day one, they're
Mm,
6'6", they can read what we call N6, which is a very small font, and they're fine. And
mm,
they adapt straight away, and it's a mystery as to us as to why some people adapt quickly
mm,
and some people take a little bit of time to get used to it. But
mm,
in the end, the vast majority of patients adapt to it, and that's just the brain learning to, I guess, look for those focal points or those clear
mm,
points in their vision and identify them and read. And it happens naturally. It doesn't
mm,
happen with effort. Like the patient doesn't actually have to put in any physical
mm.
effort with it. They just have to go on living their lives, read their books, use their computer, drive their car, go to the movies, whatever they like, and their brain will do that adaptation passively.